Hi, this is Elliot Fishman, and welcome to our latest talk. And this is going to be on the evaluation of the appendix, and I'll call it appendicitis and beyond. At the end of the day, when you mention the word appendix, the next word is appendicitis. Yet we recognize that there are tumors of the appendix, adenocarcinoma, mucocele, even carcinoid tumors can occur in the appendix, and processes such as diverticulitis or colon cancer can simulate appendicitis. So let's take a look at this important topic. First, we'll look at some of the parameters and points that people have made previously. This article by Morris. Appendoliths are incidentally discovered by CT in about 4% of asymptomatic patients. However, about 40% of patients with acute appendicitis have appendoliths seen on CT. Ranieri showed that in 248 patients with acute appendicitis, the presence of appendoliths was associated with more extensive or severe inflammation and increased risk of perforation. So again, this will tell us, look for the presence of calcifications or appendoliths in the appendix proper. It may not always be diagnostic of appendicitis, but when there is inflammation present, it is diagnostic or part of the diagnosis, but it also means these are patients who have potentially a more difficult course. Acute appendicitis is most frequent during the second and third decades of life, whereas children 9 years of younger have the lowest incidence. Appendicitis is more common in men compared to women, who have a lifetime incidence of about 8.6% compared to 6.7% with women. Sometimes data is somewhat interesting. Patients with higher income and education have a lower incidence of acute appendicitis. Hard to explain that. The incidence of perforated appendicitis has been increasing despite a decline in the overall incidence of acute appendicitis. Men are more likely to have perforated appendicitis than women. In this article by Morris, also makes the point, CT is a cost-effective tool in guiding management because its application in patients with suspected appendicitis leads to fewer negative appendectomies. Remember, a surgeon operating for appendicitis should basically have 100% of the patients have appendicitis, avoidance of unnecessary hospital admissions, and proper identification of alternative diagnosis. And I mentioned at the beginning things like diverticulitis or colon cancer or infections like typhlitis, TB. Other possibilities can simulate appendicitis, but CT is very good about picking what patients have appendicitis and making alternative diagnosis. It's also useful in pregnant patients. The more frequently now people are doing MR to help decrease the radiation burden. CT findings of appendicitis, such as appendolith, mass effect, and a dilated appendix over 13 millimeters, are associated with a higher risk of treatment failure of an antibiotic approach first. Now, we see that all the time, probably you do as well, where they try to treat select patients with antibiotics, treating appendicitis as inflammation, treating it like it's diverticulitis, treat with antibiotics, and hope it will resolve on its own. Sometimes this happens. Often it's not very successful. Patients have persistent inflammation or can develop abscesses and the like. In patients without high-risk CT findings, either appendectomy or antibiotics can be considered as first-line therapy. In unfit patients without these high-risk CT findings, an antibiotics-first approach is recommended, and surgery may be considered if antibiotic treatment fails. I will admit, and probably your experience like mine, is most patients with appendicitis or suspected appendicitis are going to surgery. In this article by Hunsaker, recently published, the diagnosis of appendicitis is not always straightforward. Presentations may be atypical, and there are a number of other pathologies that can mimic the diagnosis. It's important to systematically approach each imaging study with a broad differential diagnosis and a basic understanding of the overall medical history. Despite the complexity and broad differential, appendicitis accounts for about half of all right lower quadrant inflammation. A systematic approach and search for secondary signs will help the radiologist differentiate an equivocal appendix from true appendicitis. So again, we need to look at what we need to see. So let me show you some examples. Here's a classic case. You can see air in the appendix. Now, you can see air in the normal appendix, and there's a small stone there as well. But then there's inflammation around the appendix. The appendix itself is inflamed, and there's inflammation tracking by the colon. There's no differential diagnosis. Classic acute appendicitis. Another case, very similar to the prior case. Thick wall appendix, it's distended, it's over 1 centimeter, there's stranding around the appendix and inflammation tracking near the cecum. Again, the diagnosis is appendicitis. Here's another case. Appendix is markedly dilated and thickened, and there's more inflammation tracking downward toward the cecum. Very nicely shown. And another example of inflammation, a dilated appendix, that enhancing wall of the appendix, which is also a very helpful sign of appendicitis. Coronal views are very helpful because sometimes are you really dealing with the appendix or a small bowel loop? Occasionally you can't confuse a Meckel's diverticulum, but here's the appendix, nicely originating from the cecum, thickened wall, inflammation, very, very classic for appendicitis. Another example, wonderful case because there's inflammation, there's a thickened, dilated appendix, and there's a stone right in the middle of the appendix. This is like a 10/10 first-year resident diagnosis. Here is a couple more images showing you the dilated appendix and the stone that's present, very nicely shown there, and in these images as well. How dilated the appendix is, how long the appendix is will vary. Typically, people say above 1 centimeter or 13 millimeters is kind of the magic number for a dilated appendix. As I mentioned, not everybody with a stone in the appendix has appendicitis. 4% of patients will have stones, but once you see inflammation, as in this case, it's a very easy diagnosis. Another case, right lower quadrant pain, and you could see the stone right there, okay? Very nicely shown, and it's particularly nicely shown, inflammation around the appendix, but you see that's the terminal ileum, that's the appendix, right? Coming right off the cecum, there's the stones, dilatation and inflammation. Very easy to make the diagnosis. I do find that looking at the coronal views are very helpful. Again, as I mentioned, particularly in skinnier patients, is it appendix or is it small bowel? You can be fooled if you're not careful. But when you look at the coronals, as in this case, it's really clear what is going on, where the relationship of the appendix is to the cecum, and what is small bowel, and what is specifically the appendix. So again, scrolling through the coronal views is a very important job. Now, most patients with appendicitis will get surgery. They'll be out of the hospital in 24 hours, and they will be fine. Other patients can have complications, perforation, periappendiceal abscesses, and even peritonitis. Perforation is more common in patients with appendoliths, as appendoliths seem to increase the probability of perforation. Periappendiceal abscesses are the most frequent complication of perforation. It's often in patients with a delayed diagnosis. And peritonitis, interestingly, is more common in younger patients. So here's a patient with surely acute appendicitis, markedly dilated appendix, lots of inflammation nearby, but as you can see as you scan a bit upward, inflammation tracking by the ascending colon and tracking near the transverse colon. This is appendicitis with abscess, local inflammation, and the patient seems to be on the way to develop peritonitis. There's a fluid collection by the right rectus muscle, nicely seen, and this is a perforation with abscess. This patient sometimes will be treated with interventional drainage first and then get appendectomy. Sometimes the patient will get appendectomy and the drains will be placed at that time as well. Another patient, right lower quadrant pain, dilated small bowel. You see an inflammatory process. You can go through all sorts of things from Crohn's to infection, enteritis of the small bowel. But then you get further down and you recognize you're dealing with an appendicitis. But the patient has free air. You can see very nicely the free air here next to the dilated inflamed appendix. This is a classic case of appendicitis with perforation. And you can see in the coronal views the extent of the perforation. You can see the inflammation is tracking down into the root of the mesentery. You can see why sometimes patients with appendicitis present with midline pain, because it's the inflammation tracking centrally that's causing their symptoms at that point. But a really nice example of extensive inflammation with perforation. And again, the question about oral contrast for appendix. In the older days, the early days of CT, you would give patients oral contrast and wait 3 hours. The surgeon didn't like that, but at least you didn't have to come in to read the scan. It was a great delaying tactic. These days, nobody wants to wait more than 30 minutes if they want to wait at all. You can give oral contrast that's positive. That can be helpful if you need delayed scans. But most of the time now we use water and we're able to make the diagnosis. But in this case, you can see the dilated small bowel, the inflammation, the dilated appendix. Now, this article by Haro goes back about 2 decades. A dedicated search for 5 specific CT findings allowed a sensitivity of almost 95% for perforated appendicitis. Among findings with 100% specificity, a focal defect in the enhancing appendiceal wall achieved the highest sensitivity. Though I will admit, seeing a perforation in the appendiceal wall is kind of difficult. In this article, made the point that some of the findings that resulted in poor sensitivity for the diagnosis of perforated appendicitis were seen, but you realize that things like abscess, extraluminal air, extraluminal appendolith make life very, very simple. Although inclusion of phlegmon increases sensitivity, it decreases specificity. Alternatively, inclusion of a defect in the wall yielded high sensitivity while preserving specificity. So again, it's somewhat a challenge. I think this article goes back a number of years, as I mentioned. Considering the 5 specific findings separately is not clinically useful, since the sensitivities of the individual findings are small, ranging from 20% for an extraluminal appendolith to 64% for a defect in the enhancing wall. So again, looking at multiple findings, I think that's really the main thing I take away from this article. Looking for 5 specific findings: extraluminal air, extraluminal appendolith, abscess, phlegmon, a defect in the enhancing wall, makes it about 95% accurate for the diagnosis of perforated appendicitis when evaluating a group of patients with known appendicitis. So again, I don't think it's that difficult. The main thing is making the diagnosis of appendicitis. When you see significant amount of fluid or air present, you're going to read appendiceal abscess with perforation, and surgery is going to be done. Now, one thing that is true, sometimes if you really see an impressive abscess, then what the surgeons will do is an open laparotomy rather than a laparoscopic surgery. With just inflamed appendix, exploratory laparotomy is not necessary, right? It's too much surgery for a minimal diagnosis. They do it with scope. And with the scope, the patient's discharged in less than 24 hours. Now, some examples: appendiceal abscess, large stone in the appendix wall is thickened, inflammatory mass around the appendix. Another example right there, perforation, free fluid, the appendix right there. There's a break in the wall of the appendix. That's that appendiceal perforation we spoke about a moment ago. Here's another case. Inflammatory changes, right lower quadrant, but again, this could be diverticulitis, it could be Crohn's disease, it could be appendicitis. But then you look at all of the images. When you look at all of the images in sequence, you recognize you're dealing with a dilated, inflamed appendix with an appendiceal or periappendiceal abscess. So again, it's looking at all the images. This case also reminds me to remind you that I do not like to rule out appendicitis without IV contrast. I think IV contrast is critical in looking at bowel inflammation, also looking at other organs from the liver to the kidney to the spleen, but it does enhance the bowel. And when you're able to enhance the bowel, changes like inflammation, changes like perforation are all going to be easier to see. So a beautiful example here of acute appendicitis with inflammation and abscess present, very nicely shown. You can see the mesenteric vessels tracking toward the right lower quadrant, the ileocolic vessels, very nicely shown, and this inflammatory phlegmon, nicely illustrated. Another case, dilated appendix. You can see very nicely as you go here, the appendix, which is there with inflammation, perforation in the wall, and then the inflammatory process tracking down to the right lower quadrant. Again, the coronal views are very helpful in showing you the extent of the inflammation. The appendix, we all know, has variable appearances and positions from inferior to more posterior. So there will be a range of appearances of appendicitis simply based on the origin of where the appendix is located. And this is very nicely shown. And I'm giving you a number of different images to give you a feel of how, if you're scrolling through the data set, you can see very important inflammation. And again, the tiny extraluminal amount of air in this case is very nicely shown. Now here's an easier case, pneumoperitoneum fluid. Now you can have a number of causes of this type of abdomen, right? This is really a pneumoperitoneum with peritonitis. Appendix is one of the causes, particularly in younger patients. You can see as we track down with this inflammation in the right lower quadrant, at times when there's so much inflammation present, it becomes difficult to define the exact source of the inflammatory process. But in this case, we could see the dilated appendix. And when you look at the reconstructed images coronally, the appendix has air, it's enhancing, it's irregular. This is a perforated appendix with abscess, pneumoperitoneum, and peritonitis. Again, the coronal view makes it much easier to see than on the axial views. Now, I mentioned before an appendicitis in pregnant patient. Again, we try to do lower dose. It's a very quick diagnosis. Some people use MR, and MR is a good study to do, but at 3 in the morning, you may not have MR available. Now, one of the challenges with the pregnant patient is you got to find the appendix, because particularly when patients are later on in pregnancy, the entire pelvis is filled with the placenta and uterus and fetus, so you need to be very careful. Here you're looking and you're saying, I know there's some inflammation toward the right lower quadrant, but do I see anything? Can I call this appendicitis? There's a little bit of fluid by the rectum, so there's some inflammation, but it's only when looking at all the images, and in this case scrolling upward, the appendix was pushed higher because the colon was pushed up, and that's the appendix with appendolith, and that's the patient's acute appendicitis. So when you're doing rule out appendicitis in the pregnant patient, particularly patients in their second or third trimester, it's a challenge to find the appendix, but first look where the cecum is, then look for the appendix. The cecum is going to be high toward the right side of the abdomen, which means the appendix is also going to be high in position. So a very nice example of acute appendicitis in a pregnant patient. So just a really good example. And there it is right there with the appendolith in place. Patient had a laparoscopic procedure. She did fine. The baby did fine. all's well that ends well. And here it is, the placenta and some of the inflammation on the cinematic views. Now, another thing to consider with appendicitis is that not everything in the right lower quadrant that's inflamed is going to be appendicitis. I mentioned before there's a few different diagnoses you need to think of. Right-sided diverticulitis is one of the most common. Cecal carcinoma, lymphoma, Crohn's disease. There's a range of things that involve terminal ileum, cecum, and even appendix. So let's do this. Let's take a 5-minute break and let's come back and start speaking about them. See you in a few minutes. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.